Good evening, everyone, and happy Monday. Welcome to tonight's webinar. My name is Adam, and I'll be your moderator. I'd like to welcome back Dr. Stephen Vorholt as he discusses 3D printed surgical guides for same-day implant placement. Tonight's webinar is also sponsored by SprintRay. If at any point you have questions, please feel free to type them into the Q&A section, and we'll answer them live at the end of the presentation. And Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Dr. Vorholt, welcome back.
Hello, thank you. Today we're going to talk about 3D printed surgical guides for implant placement, and we're going to do a live walkthrough through a couple different softwares, and then at the end we'll go through the actual surgical case. I got a lot of photos to show of how the case actually wound up. So a lot to get through, so let's get started. First, if you don't know who I am, I'm Dr. Stephen Vorholt. I graduated from The Ohio State University in 2013, go Bucks. I stayed in Columbus, Ohio for several years, about 6 years after graduation. I had my own scratch start. I started placing dental implants in 2015, and since then have placed hundreds and actually helped train people to place thousands more. So my newest job, I sold my private practice January 2nd, 2020, talk about good timing, and moved to Phoenix, Arizona to work full-time at Implant Pathway. So my job here as the surgical director is to see all the screenings, all the follow-ups, all the restorations, and kind of see the cases all the way through. So I've kind of become known as like the complications guy because I just get to see such a volume. So I've gotten to see and lecture on a lot of implant complications as well as other facets of implant dentistry. And one of my favorite parts of implant dentistry and dentistry in general when I was in private practice was the digital revolution and digital scanning and surgical guides and 3D printing and all that kind of stuff. So I'm happy to be speaking on that as it pertains to dental implants tonight. I also am NYU AGD residency faculty member for the New Horizons Institute. So we have 4 awesome residents this year who are going to get totally engrossed in a whole range of dentistry, but certainly a focus on dental implants. So we're really excited. They've been here for a little more than a month. I do host the Implant Pathway podcast, which is a little more of the behind the scenes at Implant Pathway. We interview mentors, attendees, faculty members, and that sort of stuff. I've recently sat for my board exams at the AAD and the ABOI, so hopefully hear back soon if we passed. So that's a little bit about me. If you want to follow me on Instagram, that's kind of where I do most of my social sharing. I post all sorts of stuff, a lot of complications. Like I mentioned earlier, I'll post on Instagram and how we manage those complications. When we do surgeries, I'll take a lot of photos. I'm a really big dental photography person, so I'll take a lot of photos and do case reviews on Instagram stories. So follow me at Vorholt DDS if you want to see a little bit of gory stuff in your feed. Maybe make sure you'll see that sensitive content. Disclaimer quite a bit if you follow me there. So tonight, we're going to be talking about the principles of implant treatment planning. So a brief review. I'm sure most of us who are joining tonight can have a semi or pretty good solid foundation of implant dentistry. So we'll talk about that, and then the rationale for guided surgery, why we would do guided surgery, how we would approach it, and the pros and cons, because it's not a panacea. There are issues with guided surgery. We'll do a live CBCT walkthrough through Acteon's AIS 3D software, which is what we use here at the clinic at Implant Pathway. And they also have a guided portion of that software that we'll walk through. And so we're going to kind of do a case review as if the patient arrived. We're going to work it up. We're going to create the digital guide, and then we'll kind of do a cooking show method where we go, ta-da, here it is. And we'll show you how the surgery progressed. We'll do SprintRay, like Adam mentioned, is a sponsor tonight. So we're going to be utilizing all SprintRay products. So we'll go through the SprintRay printing protocol and show you kind of the hands-on. I have a couple models I've printed that I can show through my webcam, just so you guys can see a little bit more view on that. And then, like I said, we'll do the surgical case review. So thanks once again to sponsors of Implant Pathway, SprintRay, and Acteon North America for allowing us to use their technology and show it off. We're really happy to be doing that. So let's talk quickly about implant spacing. The rules of implant spacing are there because of blood supply. And without blood supply, there is no healing. So I always tell people, if you were to pull a tooth to do grafting or to do an osteotomy to place an implant and that hole is not bleeding, you need to make that hole bleed, because without blood, we have got no potential for healing. So the one thing that's special about teeth versus implants, of course, is the PDL. And the PDL is a highly vascular structure that allows implants to get closer to teeth, to natural teeth, because there's that extra vasculature there. And that is why two implants have to be further apart than they can be to natural teeth, because all the blood supply from two implants is coming from the cancellous bone and the medullary bone. So when we're talking about implant spacing, it's going to come up in tonight's case. We cannot get within 3 millimeters of implant to implant surface, or we could run into some issues. And that is on average and mostly at the crest. The apex of implants can certainly get a little bit closer than that for angling implants and whatnot. So when we're talking buccal lingually, so you have a cone beam, so now you can see in the third dimension, we're going to be talking about the buccal plate. And the buccal plate is sacred. And one of the first things you learn when you start doing implants and you start doing extracting and grafting is you need to take teeth out atraumatically, because that buccal plate is not hard. It's easy to lose and not easy to regain. So when we place implants, for the same reason, we need that blood supply on the buccal. And so if we have less than 1.5 millimeters, we see markedly more bone loss, and we can get crustal bone loss, and that can lead to gum recession and irritation and constant problems. So on the lingual, we can cheat a little bit less. The lingual plate in the mandible tends to be much thicker, so it's a little more resilient to that. And the lingual or the palatal on the maxillary arch has much more blood supply. So we know that attached tissue on the palate is very vascular. So sometimes on the lingual, we can cheat. So if you got to pick one, that's the way we're going to go. Okay. We're also going to stay away from vital structures. Obviously, we don't want to be poking these things into nerves, into sinuses, into blood vessels, that kind of stuff. So before we talk about where an implant needs to go, we have to know what's going on top. Are we doing an overdenture? Are we doing a fixed full arch? Are we doing crown and bridge? Are we doing a cantilevered prosthetic? So without the wax up, or at least a good idea of where the tooth should be in space, we're going to have a hard time picking the appropriate place to plan our implant. This is going to come up tonight, obviously, as well. So why would we do guided surgery? It's certainly going to increase our accuracy. If it didn't do that, why would we ever do this stuff, right? We're going to bring a plan that we put on a computer into the patient's mouth. Okay, we're going to obviously avoid some of the stuff we want to avoid that we just talked about. And after you've gotten used to it and you're pretty comfortable with your kit, it is going to increase your surgery speed. Now, that doesn't mean you should do the surgery faster. In fact, that can lead to some more problems. But from setup of the room to the patient being dismissed can be a lot more predictable, and the speed can be a little bit faster. There nowadays, especially, there's lower cost in-office options. It used to be pretty expensive to have a lab fabricate a guide for you. We're talking $300, $400, $500. And it would be weeks before you got it. Nowadays, with printers like from SprintRay, we have a lot more access for in-office, even same-day treatment planning. Okay. So increasing accuracy. Every time I use a guide, I take this photo. Once the implants are in, I call this the money shot. If you don't take this picture, I don't believe that you did a guide. Everyone loves this photo because you want to see the implant through the guide sleeves. And certainly it confirms a little bit of your accuracy. So we want to use guides to increase our accuracy. But I always stress, you do not want to only use guides when you're trying to thread the needle. And a lot of these cases that I show on the screen right now are anterior cases, which are great cases for guided surgery. But you don't want to only get the guide out when it's pivotal that you put something in the right spot, because you don't want to be fumbling around with a kit you don't use a lot, or running into problems that you would have found out if you had done this more and more often. So I think guided more often than not is probably the approach that is best suited for implant dentistry. Okay, bringing your plan to life. On the left, we have a overdenture case planning that I had done in private practice, and certainly anybody with a cone beam CT and software can say, this is where I want to put the implants. But guided surgery can physically bring that into the operatory with you, into the patient's mouth, and kind of make that plan a reality. We already spoke about this, but certainly avoiding things or getting right up to the sinus floor, like in this case, avoiding undercuts, certainly avoiding nerves. All these things can be very helpful with guided surgery. Hopefully, a lot of you already have some of this technology in your office, some digital technology, 3D printing. I was a CEREC doctor back in Ohio, so I had made one CEREC guide, it made an absolute mess and a horrible, horrible noise that I made that one. And thankfully I got a photo of it because that's the only one I ever made. After that, shortly after that, I bought a 3D printer and never looked back. And I mean, we're talking $3 per guide in the materials cost, right? The resin cost. So the cost has really come down, and let alone the cost, but the timeline, the ability for you or a staff member to make this and turn it around in less than 24 hours. Okay. Sometimes if we don't plan with the end in mind, we can run into problems down the road. So you might have started your implant journey and everything was going great for 4 months until your implants came back to be restored. And then we realized, oh, that's why I wish that had been angled this way or a little bit different this way. Some of these cases are mine. Some of these cases are cases that Dr. Moody's lab has seen when they came in. But like the case at the bottom right is a prime example of a perfectly placed implant. It healed. It will be totally restorable. However, it's going to require some sort of custom abutment, some sort of more expensive restorative plan from a lab than if it were a simply placed screw retained crown. That would have been much simpler to restore. So we have to start with the final prosthetic in mind. Case on the bottom left, case I did guided and took the impression the day we did the surgery, buried the implant, and when the patient came back in 3 months, we did the uncovery and delivered the final prosthetic because we knew everything was planned before we did the surgery itself. Now, there are issues with surgical guides. If someone does a lecture and says surgical guides are the only way to go, which I might have given a lecture like that 2 years ago before I kind of knew any better, there are complications that can certainly happen with guided surgery that you have to be aware of. It is not something you can just put in the mouth and forget about it and it's going to take care of it for you. Okay, we are critical thinking doctors on the other end of the drill that we have to be very mindful of what we're doing. So one of the biggest things is it can reduce the tactile sensation. So if we're talking D1 through D4 bone, if we're talking sinus floor, if we're talking lingual plate, things that would naturally give an implant surgeon some sort of tactile feedback on the drill, sometimes in the guide sleeves, because the tolerance is so tight, we can lose some of that feedback sensation and it can lead to problems. Case in point, if you were to accidentally grab the longer drill, maybe your staff member put it back in the wrong place in the guided kit, and you grabbed the 21 millimeters instead of the 17, and you were just in the groove and used to it, and you didn't notice there's a little bit more, problem, a little bit more tightness in the guide. You thought, I'll just drill right through it, and now we're in the sinus or under the lingual plate or something like that. So reduction of tactile sensation is a real concern with guided surgery. Poor fitting guides can be more problematic by far than doing something freehand. And I have an example of that coming up soon. But if a guide is rocking or was incorrectly stitched to the patient's cone beam, we can actually think we're doing everything perfect through the guide and wind up being in somewhere we don't want to be, right? Patients with limited opening, the classic example of the little old lady who can barely open her mouth. Some of these guides require longer drills, and we should, before you spend money or time designing a guide, make sure that patient can comfortably open to the limit that they need to. When we're talking about edentulous ridges or narrow spaces, things can get a little more complicated there. Additional cost and time. The cost nowadays is minimal, and the time is getting shorter and shorter if you're willing to invest in some of this newer technology. If your surgical plan were to change mid-surgery, we can certainly run into some problems there. I think everyone who does guided surgery needs to have a really solid foundational understanding and understand how to comfortably do freehand surgery, because sometimes the guide might not fit. The guide, God forbid, the patient bites down and breaks your guide, or they can't open, or whatever reason, you flap the surgical site and realize the bone is worse than you thought. You need to be able to say, okay, well, it was nice to have that. Let me put that aside and get to work anyway. And then the other two that are also kind of major players, visibility being reduced. We're not able to visualize the site directly as easily. Some of these new surgical guide materials are clear. They're not super opaque, but at the same time, you're looking through something, some sort of resin. And then irrigation being impeded. Most of our drills are not internally irrigated. I wish more of them were. It makes a lot of sense for guided surgery, but most of our drilling is externally irrigated. So the sterile saline may hit the guide rather than the osteotomy or the drills. And so it's a slightly different drill technique where we're a lot more into slow, methodical, and we're pulling out a little bit more, and we're allowing that water in the osteotomy to get flushed out with cold, sterile saline, rather than just going as quickly as possible, where we can burn up the bone and cause more problems. So here's one example of a guide that was ill-fitting, and the implant that I had placed in the number 4 site, this was always planned to be a cantilevered 3-4-5 bridge, with 5 as the cantilevered ponic. That one is placed correctly, and at least to plan, right? And number 3, that guide, and you'll notice the guide is a distal extension. The patient has no teeth behind in this whole quadrant. So as we were pivoting with my finger rest, the tuberosity gave a little bit and the guide shifted, and I didn't catch it, even with the window in the front. It was my mistake to not critically think. It just got in the groove. And lo and behold, now my implant is placed at 2 divergent angles. And I guarantee you they were not planned to be divergent when that plan was made. So they were supposed to be perfectly parallel. So it led to some restorative compromise, and we had to get kind of creative with how we restored it. The pier abutment ended up becoming a screw retained pier abutment that was then cement retained with the bridge. And it ended up working out, but boy, this was a lab bill that I had to swallow that I wasn't really prepared for. When I first started the case, it looked like a slam dunk, perfectly parallel, double screw retained cantilevered bridge. So, being very mindful of distal extension guides, this is a mistake. Hopefully I only make once. Now we could do a palatal strap or a more full arch guide or some sort of bone foundation guide or even a bone retention pin guide in a situation like this. So, the guides are not just snap them on and drill through them and everything will be perfect, right? So here's another example, a case I did more recently, about 6-7 months ago, where we decided we wanted to place 4 implants for an overdenture. The patient could not tolerate an RPD, believe it or not. The teeth in the front were loose, and number 18 was very carious and non-restorable. So the only tooth that still had any hope was really number 19. And we decided it was better off to remove and restore as an overdenture. And you can see in the CBCT slice here, very thin ridge, not even much cancellous bone. So, the guide had to be perfect so that we could get this done. And so the plan here was to make a guide that would rest on the canines in number 19. So digitally extracted number 23 through 26 and made a guide that would rest on a tripod. And you can see the guide design there on the right. And what was probably overlooked was the fact that 22 and 27 were a little bit mobile. I did not use them to leverage off of when extracting 23 and through 26, but the teeth, just from periodontal disease, they were a little bit more mobile. But I thought with the tripod, everything seemed to fit pretty tight. I thought it would be okay. So we put the guide on and we're using the 2 canines in the molar. And the one issue with this design is I cannot do alveoloplasty before I place my implants. So I have to place my implants very deep. So I do my alveoplasty before or after the osteotomies are done. So the 4 osteotomies are done. You can kind of see them here in the premolar sites and then the 2 lateral sites. And after the osteotomies were done, we removed the rest of the teeth and we started to do our alveoplasty. And so here you can see I've circled where the osteotomies are versus what the plan was, and everything's looking okay. And as we start to alveoplasty, we notice that the posterior osteotomies are not centered in the ridge anymore. And what ended up happening was, due to the mobility of the canines, the whole guide had shifted probably about 10 degrees. It wasn't a huge amount. Of course, we didn't have much to play with in a case like this. And so we actually have a buccal strip perf entirely the way down the buccal plate on number 28. And on number 21-20 site, we had a lingual strip perf, which, if you're familiar with full arch mandibular surgery with implants, a lingual perforation is probably the worst thing that can happen, especially through a guide with no knowledge. So the lack of tactile feel, drilling through the cortical plate. Luckily, there was no injury to any vessels or arteries on the floor of the mouth. The patient wasn't bleeding. There was no pain. But we weren't able to place implants in those posterior sites that day. So we were still able to place our 2 anterior implants, and we added 2 mini implants to immediately pick up the patient's immediate denture to add for some stability while we allowed those sites to heal again. So quickly, we're going to go through the BioHorizons Guided Surgery Kit, because if you're not familiar with it, the pictures later might not make a lot of sense. But essentially, the BioHorizons Guided Surgery Kit is a keyed kit or a spooned kit, which means there are master guide sleeves that are a certain diameter, say 6 millimeters. And we have these keys that you see the arrows pointing to that will reduce that diameter down to the diameter of whatever drill you're currently using. So there'll be a certain key to reduce that sleeve diameter to 2 millimeters, and the 2 millimeter drill then goes through that. So it's an extra thing you have to hold, or your assistant has to hold, but it does allow you to go all the way to final depth on each drill. Whereas a keyless kit, which is where the keys are built into the drill itself, is advantageous in that you don't have to have another piece of equipment in your left hand or in your assistant's hand. However, you cannot go straight to full depth because you need to have that engagement of the sleeve. So in any case, BioHorizons, this kit is a keyed kit, and everything's color coded like most things are in implant dentistry, because no one thinks dentists are that smart. We all need little color coded, and so we can do things smartly. So green goes to green, yellow goes to yellow. They have different lengths based on the plan. So on the left, you'll see an example of a drill protocol. So for the middle column here, 4/6 by 12, we're going to use the 24 millimeter drills, and we're going to use SP3, which stands for stop position 3. And so on the guided kit, you've got 4 rows. Each row is a different length. And this is where your staff have to make sure they put the things back in the correct order. There are laser engravings on the shank of every burr that says 2.0 by 17. So always double check before you place it in your handpiece that you have the correct burr. I've caught it once or twice where I had the incorrect length because it had been placed in the wrong grommet. So just make sure that you always double check that. But there are 4 different lengths in the BioHorizons kit based on the offsets and what length implants we're going to be placing. And then as you go left to right, we increase diameters like most surgical kits. So we're going to go over, and we're going to use our critical thinking skills to know if we need to undersize or go to full drill diameter. Lastly, there is a stop position depth placement, a guided depth placement carrier. So this carrier goes through the guide, so it's a fully guided system. And then you'll see here in the middle and the bottom with the little notches, there's SP1 through SP4. And so based on the offset and the length of drill, and either your lab or your guided surgery software will let you know which one to use, you're going to insert the implant through the guide to that stop position so that you have the correct vertical. So final example of that, using that stop position, this little fork will go into one of those notches, and once it hits the guide, you're at the final depth. Okay, so we've gone through the kit. We've talked a little bit about guides, the pros and cons. Now let's talk about some CBCT case review. So when we're talking about planning implants in a cone beam software, we have 4 magnitudes of prosthetically driven planning. Okay, we already have a 3D X-ray. That's a given. You have to have a cone beam to do implant surgery guided for sure. So CBCT alone planning, we have a 3D rendering of the patient's jaw. And we can use that and some critical thinking to say, here's generally where the central grooves are. Here's where the middle of the ridge is. I can plan the implants and see the angulation of those placements. So this is what some will call brain guided, which means I'm able to look at my cone beam software in the operatory, make measurements, double check different things and spacings and nerves and arteries and plates and whatnot, and then go to the patient's mouth and bring that information with me in my brain, right? We can also import STL models. So an STL model is a digital model, usually a soft tissue and tooth model that we can then overlay onto the patient's 3D X-ray. So if we are to bring in, like in this example, this patient's STL, we can now really see more clearly because there's less scatter and the 3D rendering is not not the most accurate. So now we have a much more accurate digital impression. We can see, okay, here's where the central groove really is. Here's the soft tissue contours. Where can we put these implants, or where should we put these implants? Still brain guided at this point. We're still not physically bringing anything with us. The next step from that is to do a digital wax up. So whether your software allows you to add teeth and orient teeth in the software, or you have a digital lab that allows you to do a digital wax up and email you back or Dropbox you back the file, and you can import that. And that's even more accurate as far as where the implants need to go. Okay. The next iteration of that obviously is to make a guide. So now you've got the perfect placement, time to make a physical representation of that you can take to the patient's mouth so that you have a little bit of help putting those in the exact right positions. When we talk about how to make guided guides for surgery, we need this equation. Okay, we have cone beam, we need the STL, so a digital model. You can also use, you could get a polyvinyl impression, send it to a lab, have them scan it for you. If you don't have an intraoral scanner, you can buy a desktop scanner. You could pour up a stone model and scan it in your cone beam. All fine options. More accurate ones are going to be the intraoral scanners and having a lab scan it for you. You need a software like the Acteon AIS 3D software to mesh these two things together and plan where the implants go. And then that will spit out a surgical guide STL. And an STL, like we said earlier, that is simply the digital file. That is a file type. It lives on your computer. It is not a physical thing. So how do we bring that into real life? Well, there's two options. You can 3D print your digital file into something that is real. And certainly a lab can 3D print it for you. You can 3D print it in office, or we can do some sort of CAD/CAM computer-aided billing. It's like the CERAC guides, or having a lab do a milled guide for you. So those are kind of the two most popular ways to turn your digital file into something you can physically use. Okay, we've gotten about 25 minutes worth of a quick run through implant and guided surgery rationale. So let's take a look at our patient. So patient presents missing a couple teeth. We are partially edentulous. We are missing the upper right first premolar and the upper left lateral incisor and canine. Otherwise, the patient is being treated for previous periodontal disease in the molar region, but these sites in the teeth around them are relatively healthy. So we take a look in the patient's mouth, and here's what we see. Okay, we have a little bit of space that we've lost in the number 5 upper right first premolar. The PA there shows that the sinus is well away. So we're good there. We don't have to do any sort of sinus surgery. The canine root tip does have a slight distal bend to it, so we'll have to be mindful of that. And on the patient's left, we have a space for a lateral and a canine. And what's very, very common when we talk about anterior implants, especially when we're missing 2 teeth in the anterior, is that we're not going to have that space for that 3 millimeter gap between implants. Because if we add together the 1.5 millimeters we need from the teeth and the 3 millimeters between the implants and the 1.5 millimeters behind that for the next tooth, that's almost 14 millimeters of space, depending on the size of the implants we're trying to plan. And it's very difficult to find 14 millimeters of space in the premaxilla. Okay. So oftentimes what we do is we'll use a cantilevered bridge option, and we'll typically utilize the central or the canine section, depending on which teeth are missing, and we will cantilever the lateral incisor off. And we're making sure to control the occlusion, no excursives, no excessive contact in MIP. But and you'll see this as we go through the CT plan, it's really, really difficult, if not impossible, often to fit 2 implants. And if we force it and we try, what ends up happening is we get bone loss, which is the gum loss, which is an extremely unaesthetic nightmare in the patient's aesthetic zone. So we're going to switch over here to our cone beam. So here's our cone beam. Our patient Robert enters, and we're going to take a peek at the cone beam here. So this is the Acteon software, and this is true for most all cone beam softwares. You're going to start with this screen. You're going to have the 3D rendering, the coronal, sagittal, and axial slices, and this is called the scout view or the scout plane. And this is true in, like I said, most CTs. And what I'm going to do is typically take a look in the patient's scout plane and kind of do a quick review. So I'm going to go all the way to the top. I'm going to come down. I'm going to be taking a look at the nasal. I'm going to take a look at the sinus. I'm going to be looking for deviated septums. I'm going to be looking as I get to the apex of the maxillary teeth for any abscesses, any fractures. And we'll see one right there, right in the middle of number 9 here. You'll see, boom, a fracture right in the middle. And that's from a childhood injury the patient had, completely asymptomatic. So not something we're going to be worrying about. But of course, I did notice that and ask him about it. As we work our way down, we're going to be looking at the mandibular teeth. Patient is also missing clearly his mandibular anterior teeth, which we did treat in this surgery as well, though we're not going to talk about that tonight. And then we're looking at, any abscesses at the base of the mandibular teeth, where the mental foramen are, the anterior loop, and so on and so forth. Okay. We'll also take a look at the sagittal slice, and we'll take a look in the posterior section, look at the sinus, a little bit of sinusitis in the patient's upper left side. As we come across the anterior, we notice an undercut in the number 10, 11 spot. There's our fracture again in number 9. And as we come around, we're going to look at the upper right. And here's the inactive or active periodontal stuff in the molar region that we can see there. Some of the vertical bone loss and a little bit of sinusitis as well. As we come finally into the coronal slice, we're looking from the back and we're coming forward. Get a really nice view of the sinuses here. We're looking to see at the top of the sinus, is the ostium patent or not? And right there, you'll see the ostium here in the upper left and the upper right. So the ostium is patent. So this sinusitis could just be a chronic sinusitis. Not something we're going to be looking at in this surgery. But as we come forward, we're looking mostly at the position of the nerve, mental nerve, where it exits, and so on. Okay. Next thing we're going to do, most important, we're going to draw our panoramic curve. So since we're focusing today on the maxilla, I like to make my panoramic curve level with the hard palate. It helps me to reposition the patient if they weren't positioned perfectly parallel to the floor when they were scanned. I'm going to go just about to the apex of the teeth, and I'm going to start my pano curve behind the pterygoid plates. And it's going to end up looking somewhat like a horseshoe. And I'm going to basically be aiming for the apex of these teeth right at the top of them. Okay, so a little bit of a horseshoe here. So now I have this panoramic reconstruction from my CT. I'm going to thicken this so it looks a little bit more usable. And this is the view that we had seen on the PowerPoint slide. Okay, now we're going to go forward to implant setup. And I can scan through. This is the screen I prefer to have. I have a panoramic reconstruction. I have a 3D rendering that I can kind of look at the gross anatomy. And then I have the tangential slice in the upper right. And those are the main things I'm going to be focusing on today. Okay. We're going to delete some of his lower models that are still in this CT just so we can focus on our uppers. So let's go ahead and delete this so it doesn't get too crowded. All right, so in the Acteon software, there's a little tab here called Data Import. And so I've already imported the patient's STLs, just so we don't have to wait for me to do that. And I have 2 STLs. I have an upper pre-op model, and this is the model that we saw the photo of, right? The patient with their edentulous spaces. And I have an upper wax-up model because I cheated, and I already have a digital wax-up from our in-house digital lab tech, Mark. So what I'm going to do is I'm going to stitch this together, because right now where this is imported is completely useless. It looks like the model is in the patient's nose. So I'm going to match, select this and hit match. And what's nice about Acteon is I can now look at, here's the model. So my digital tech Mark has made some ovate sites here. So for where I'm going to be placing the final restorations. And I can sit here and I can fit points. And I can click on this incisal edge and that incisal edge, which is certainly a very viable way to do it. But in Acteon software, I can simply click this assisted button and let the computer do its thing. So the computer is going to be looking for similarities in the hard tissue 3D rendering and my STL model that I've imported. And we'll see if it can stitch everything together as it thinks and thinks and thinks. And we'll see, there it goes. So it's snapped onto our 3D rendering. And you can kind of get a pretty good bird's eye view. That looks pretty darn stitched. And when I say stitched, I make sure that the STL or the soft tissue model is intimately connected to the patient's 3D scan. Because if that is incorrect, we've already started off on the wrong foot and all of our implants will be placed incorrectly. So what I'm going to look at is I'm going to blow up this axial slice. And as I'm scrolling through, what I want to see is that outline of this STL model intimately fits with the patient's hard tissue scan. And what I'm really looking at is an example just like this. Right when this incisal edge comes in, I see the outline of my STL. Right when that incisal edge comes in, I see the outline of the STL. So that is a nice stitch in the axial plane. Next, I'm going to take a look at the coronal slice. And same thing, but I'm looking at the buccal lingual here. So the buccal lingual, how nice is that stitch? Is it nice and intimate? And it sure looks like it is. And last but not least, we're going to take a look at the sagittal slice and the buccal lingual of the anterior teeth. So this looks very, very well stitched. So once I've confirmed that, I'll simply click apply. And now I have a stitched model of the patient's preoperative condition. So if we come down to teeth setup, and this is what we can do if we don't have someone, Mark, who works next door and can do a digital wax up for me, I can remove the 3D rendering and just take a look at the patient's current condition. And I can say, you know what, I want to add a tooth here. So number 5, we're going to select add in the teeth wizard, number 5. I'm going to pick a site here on the edentulous site. And it's going to try to throw in a tooth. Now, it's a little bit difficult to orient this tooth using the 3D rendering model. However, I can come over to these slices and I can grab, drag and drop and twist this model until I get it to be pretty close. And I'm looking at the opposing occlusion to get an idea too. So here in the tangential slice, I'm going to kind of put this in the correct orientation. And then lastly, in the axial slice, see, I can grab the tooth and orient it this way. So now I have a tooth roughly close enough that I can use that to plan something. So here's as if I've given the patient a new tooth. Okay, so I have a new crown there. Perfect. Now I can plan my implant to go there. Now, like I said, I cheated. I have Mark, who works with me, who is fantastic and really quick at this kind of stuff. So I'm going to instead use his beautiful wax up model that he's done, and I'm going to stitch this model as well. So same thing we're going to do, assisted. And we'll let the computer do its thinking. And now I will have a model that is preoperative. So I have the edentulous spots. That's the model I will build the guide from. And then I have a model of the wax up, and that's the model that I will use to plan the implant positions in the most correct, appropriate spot. So real quickly, we're just going to confirm that this stitched as well. Looks really nice. Axial looks great in the coronal, and the sagittal looks fine as well. So I'm going to hit apply. And then just because I want to make sure I don't confuse the two, I'm going to change the color of the pre-op model into something that kind of represents like a stone model. Okay, and then my white wax up model. Okay, so let's delete my little tooth that I put in there just so it doesn't get in the way, even though that is one way you could do it if you didn't have a Mark on your team. We're going to go to Implant Setup, and I'm going to get rid of and just kind of make invisible the pre-op. So now I have this beautiful full mouth of teeth. Okay, we're going to scroll our CT until we come to the section that is number 5. I'm going to line up the angle roughly on the panoramic curve, and I'm going to select number 5 for my implant. I'm going to go to this screen now that has every implant I didn't even know existed in this. From the Acteon software, you can download these different implant brands. And then so I'm using BioHorizons. Inside BioHorizons, I have all of their different types and lines of implants. So we're going to use BTA, which is their newest tapered pro. And then for a premolar, I'm going to take a look now at all the different sizes. Let's say premolar, I typically like to do a 4.2 by 12. And if I put the 4.2 by 12 in here, I notice, man, I'm getting a little bit tight on this buccal plate. We just talked earlier about buccal plates and what kind of width we want the buccal plate to be. So maybe I need to do a 3.8 by 12. And that's okay with me because I've still got tooth number 2, 3, and 4. And I've got all of their teeth in the mouth. So I've got a protected occlusion, and I can make sure I really protect it in the future as well. So now I've got 3.8 by 12, and I like that a little bit more. I'd rather have more bone in the buccal than an extra 0.4 millimeters in my implant in this situation. I have to avoid this undercut. This is the kind of undercut that you can get in trouble when you're doing implant surgery with a pano and a PA, and you flap and you see a nice big wide ridge, and you end up putting it right in the middle, and boom, you've perforated the buccal plate, or you're extremely thin and we get undiagnosed perforation or fenestration and bone loss. So we're going to be smart about this. We're doing a guided. We have a cone beam. We're going to place this a little bit more palatal. We're going to then take a look from the side and make sure that we're not anywhere near those roots. And we know that number 6 does have that distal turn, so we're staying well away from that. Acteon has this nice little outline here that's 1.5 millimeters, like a little safety zone outline. So if that does not impinge on any PDLs or teeth, then I know I'm in good shape. So I'm just going to get that to be the perfect angle right between the contacts. I'm trying to parallel the contact point here. And then last but not least, since we're doing a guided surgery, I'm going to pick the appropriate guided sleeve. So since it's a 3.8 implant, I'm going to grab the 3.8 by 12 sleeve. And so that's going to show up here. And on the left, I have this really nice schematic showing me all the offsets and different sizes and all that kind of stuff. So I know, hey, the offset for this implant from the guide sleeve down is 22.5 millimeters. I know my key, that little thing I need to bring into the mouth with me, is 1.5 millimeters thick. So this is going to be the 24 millimeter long drills. And that's what I'm going to use through this sleeve to place this implant. So I'm happy with that. I'm going to hit apply. And now I can really take a look at my positioning based on Mark's wax up. So I like that positioning. If I didn't, I could certainly come in here. We could tweak a couple things, but we like that positioning. That looks pretty good. Okay, so we're coming out roughly near the central groove. coming through the contacts. Maybe that's a little bit over, maybe twist it this way. And when you're doing brain guided, you don't need to be super exact, but certainly when we're going to be making a guide, a physical guide, we want to make sure that this is exactly where we want it to be. All right, now we're going to go over to number 11 and the upper left canine. And this is a bit of a tricky one too. So now upper left canines, I know I'm already planning on cantilevering number 10 off of number 11. So hopefully I can get a slightly larger diameter implant into this site. So we're going to try to go with the 4.2 by 12. And we'll zoom in here a little bit. We can see this is a pretty significant undercut. We have a defect here from the canine being lost for a couple of years. So we're going to place this implant a little bit deeper. And we're making sure I can see my wax up outline here. So I'm coming out roughly near the cingulum so I can slide this little palatal. Like I mentioned earlier, if we're going to cheat anywhere, we're going to cheat palatal because we have a nice blood supply. And we're going to stay away from this thin buccal plate. And then when we come here, we're just going to make sure that we're not impinging on the root of number 12. That looks good. We're going to pick our guided sleeve here, which since it's a 4.2, we're going to bump up to the next size up sleeve, which is going to be a 4.6 by 12. And same schematic over here, you'll notice the offset also 22.5, so 24 millimeter drills for this implant. So now I have an implant that if I had made this cingulum a little bit wider, if we increase the buccal lingual dimension of this tooth, similar to the size of this tooth, I think we'll be able to do a screw retained crown with a cantilevered number 10. For argument's sake, let's pretend like we're going to put an implant in number 10, and it's immediately going to yell at me because, hey, implants are way too close because it knows that they're impinging on that 3 millimeter collision zone. So I said, well, what if I do a really tiny implant? Let's do a 3 by 12 implant, one of those pseudo mini implants. Okay, I'll put it here, and I want to make a screw retain too because it's number 10, and we don't want to do a cement in the aesthetic zone. Even with a tiny, tiny implant and trying to cheat, now I'm impinging on number 9. Otherwise, I'm way too close to number 11. And this is the constant problem we have with anterior teeth in the premaxilla. We cannot fit two ideally sized implants next to each other without them being too close. And what is bound to happen is if we were to place these two implants, the bone between the two would die off. We'd have some horizontal bone loss, which would then take the gum. You'd have a big black triangle. You'd have super long teeth. It'd be horrible and horrible. So we don't want to do that. We're going to delete this implant, and we're going to stick to the cantilevered bridge. If we're going to cantilever anything, we love to cantilever mesial, a little bit less force. We love to cantilever to the lateral because the canine is a super important tooth, and we want the most strength to be on the canine. All right, so we like the two positions here. We used our wax up to place them in those positions. We're going to move forward now to our guide design. So when we come to our guide design, it's going to say, hey, what model do you want to use? It already has pre-op selected for me. Obviously, if we do a guide on the model with teeth, we're going to have a bit of a problem because the guide won't sit. So we're going to go back to our pre-op model. And I want to bring in the implants so I can see where those are in the model. Now, it is showing me an undercut model. So it's saying, hey, Steve, what is the angle of insertion you want of your guide? Now, when I did this person's case myself, I made two separate guides. We're going to make just one guide just for timeliness. But let's say we want to have the angle of insertion roughly so we can fit both of these sleeves down without them having undercuts, right? So we're going to say set the insert direction from view. And you'll see it'll change. And now the brown is the undercut portion. This is similar to when we were doing dentures in dental school. We had to wax out or wax block out the undercuts. So I'm going to generate an undercut model. What that's going to do is make a new model that no longer has these undercuts. So when I do make my surgical guide, I know when it goes to the mouth, it's not going to get stuck. It's not going to be able to not go down. So here's my final undercut model that I've made. We're going to go to the next step, and it's going to say, okay, outline your guide for me. So simple clicks. I'm going to be outlining my guide design. We're going to go all the way back to the molars for this one. Don't need to go too far into the gum line, just right at or below the CEJ is plenty. And as I come to the last one, I'm just going to bring the two dots together. And now I've made an entire outline of where I want my guide to sit. Okay. Essentially, what the software is going to do is it's going to make a suck down night guard. So I'm going to make a suck down on that path of insertion that I've already dictated. So now I have essentially my nice night guard. Now I have all these little tools: add, remove, smooth, and fill. I'm going to go in here and smooth these little undercuts or these weird sleeve projections that have shown up. Let's just make sure those don't get into the final model. So we're just going to quickly smooth those out. And then if you're a surgeon that likes to have a window so that you can confirm seating, which I would always recommend, we can also add a window to our guide. So in this case, I think if we're doing a full arch guide, a window straight in the middle would be really nice. And that's just so in the mouth, when it's seated, we'll be able to very obviously see that this area is all the way down and this area is all the way down. You can add windows in the back here as well. So I like to have windows somewhere near where I'm working, so that I can confirm that that area is also nice and down. And basically, we're taking a bite out of the guide here. So here's another window. And on this side, there's not too many teeth, so we'll leave it windowless. And then we'll hit next. And next is going to now extrude those sleeves. It's going to put holes in my guide. So here's our final guide design with our windows and our sleeves. And all I have to do is export the guide. So it's going to say, okay, where do you want to put it? And it's going to be a digital file. It's going to say, what part of your Windows Explorer do you want to take this thing to? Put on your desktop or your Dropbox or in your special patient folder, wherever you want to do. I'm also going to have an option to make an implant report. So this report will allow me to print off or create a PDF that I can load on the computer screen there. Then I can put all my little notes in here. I can say, patient is fantastic. Patient loves hard rock. I'm going to play that on the screen, whatever. And then here, I can type in, this is a 4.2 by 12 millimeter tapered pro implant. We're going to use 24 millimeter drills, SP3. Okay. And I also have my nice schematic here to show me, how long those drills are. So click OK, and it's going to export a PDF. That PDF, I already have pulled up because I've cheated, looks something like this. So patient's name, Robert, my name, Dr. Vorholt, what implant types they are, it's immediately loading, what type of guide, blah, blah, blah. It's got all these nice little pictures. So this is something that I will print out. There's 6 pages. I'm taping this to the wall at 12 o'clock of my surgical suite. And here again, implants 5 and 11, 5 planned for future screw routine restoration. 11 will have number 10 cantilever, and it tells me the sizes and shapes. Okay. Once more, we have a page just for number 5, and here I have a little bit more information. 3 8 by 12 BioHorizons Tapered Pro, 24 millimeter guide drills. You can see the schematic here just to double check. Plan is for a 2 millimeter pilot drill and completion of osteotomy with osteotomes for bridge expansion. So in my surgery, I decided to really just use the guides to get my pilot. And after that, because this was just so narrow, I did not want to go in with larger and larger drills and remove more bones. So we decided to take off the guide after the 2.0 pilot and use an osteotome bridge expansion technique to place these implants. Number 11, same thing, except 2 millimeter pilot and 2.5 millimeter starter drill, and then osteotomes to expand the ridge. So we get this nice little schematic, these 3 slices in the back, the front, and the middle of the implant, and then we get the 90-degree tangential view as well. So really nice to have this up. And of course, you'll have the cone beam software up as well. So once we have this and we've exported our file, we're going to load it up into the SprintRay Rayware software. And I've just imported the 2 guides that I used for the surgery. And I like to angle them just a little bit like that. And I'm going to make some supports. So for my supports, I prefer medium strength, medium density, and this road. And you'll see I hit generate supports, and pretty quickly it gives me this nice little support. And that's a 3D printing thing. We need to make sure that it is always supported as we're 3D printing with our resin. So same thing on this one, we can put some supports, and then we can fit these, change them, move them. I mean, we could fit probably 20 of these models. So if you're doing a high volume of stuff, we could have model. And in the Acteon software, there was one part in the guide software I didn't do, but we can actually add text to the outside of our guide. So you could put, Robert number 5, and then we'd know, okay, that's Robert's case. Okay. As we go to print, we've selected the correct material, surgical guide, what layer thickness, how much material it's going to require, and we can send that to the printer that is in the next room. All right. So now we've got our 3D, we're going to go back now. Our print has completed. So hopefully now you're looking at the SprintRay printers we have in our digital lab, and it's printed here, and we have our 2 surgical guides. And so I've just taken them off the build plate, and they still have their little supports on there, and those just pretty easily snap off. You can even do it with your fingers. They do have these nice little clippy calipers, and I like to use the SprintRay branded clippy calipers to put my guide sleeves in. So I've taken off the supports just typically with my fingers, and now I'm going to use these little snippy calipers. I'm sure there's an official name for that, but I'm just blanking on right now. And I'll put the sleeve in there, and the tolerance is pretty tight. So I'll just use this to kind of force it in. And as it slides all the way down, like in this lower left picture, we know that we have now our guide sleeve is fully seated. So moving on to the surgery. So now we're here, we're back. Robert's in the chair. I have my guide, I fully seat it. I check my windows. I make sure that it's not rocking. I do a minor flap, full thickness flap, lingual line angle to lingual line angle. And you can see here how misleading the bone level is, because if we were to just do this flap and place an implant right in the middle of that central groove, we would very quickly be into the buccal fenestration and out the buccal plate. So because we have a guide for our pilot, this is showing us the pilot 2.0 drill. So after the 2.0 drill, we now just take our money shot photo, right? We got to make sure we have it through the guide. And this is my osteotome setup, right? So now I'm using my Camlog convex osteotomes, and I'm just using mostly my own arm hand pressure to widen this ridge, or widen these osteotomies. So the nice technique about this, similar to like a Versa technique, is a non-bone removal technique. We are expanding the osteotomy rather than doing any more bone removal, because we know that this ridge is already so thin. This is, the implant is in, so now we have our Ostel ISQ abutment, and that's the Ostel Beacon, which is their handheld wireless ISQ reader. So ISQ reading is fantastic, 78, 79. Anything above 65 is healing abutment worthy. Anything above 70, you could even put an immediate load temporary crown on. Not something we were interested in doing in this surgery, but we were very happy with those readings, nice and tight, went in at about 60 newtons torque. So we decided to immediately place our healing abutment, and we pushed the tissue to the buccal. So we gained a little bit more tissue thickness on the buccal there. And then just our post-op PA confirming that our healing abutment is fully seated. And what's really fun is then to take the photos and compare them to your plan and notice like, oh, look at that. It's pretty much right where the plan was. Always nice to see confirmation of the plan coming into real life. So we have our planned position and our ISQ position here, and then here it is from the side. So we've got the angle, splitting the contacts, something we can make a screw retained crown. This may require a little bit of an Alveoplasty on the distal of the canine, just to make it a simple restoration to do. And we would do that at the final impression. That was when we would do the Alveoplasty there. Here's our pre-op CT slice plan versus our post-op CT slice. And we can see we've stayed well within the buccal plate. We avoided the temptation to go in the middle of that ridge, and we stayed palatal thanks to our guide. And you see the healing abutment again is fully seated here. 12 millimeter implant, plenty long here. We don't need to utilize all this bone. We don't need to place an 18 millimeter implant just because there's bone here, right? So going to the other side, now we've got a window here, a number 8, just like we did in my example. And we can see that's fully seated. So we've got our pilot hole that's been placed, same flap design, lingual line angle to lingual line angle, so that we can push the tissue buccal if necessary. And we're just showing how thin this ridge is and from the defect of not having these teeth for some time. So a little bit better picture of the osteotome. Really love these Camlog osteotomes. BioHorizons website sells these convex with an off-axis angle here and a nice large handle so you can really get a good grip. I'll put these right in the palm of my hand and use my arm to lever it up. You can also use a mallet if you need to. In this case, I do not believe we needed to. So we're going up just in larger and larger diameter. So especially because we know this site, number 11 and number 10, are very, very thin buccolingual from not having those teeth and the resorption. So we're really not interested in removing any more bone after our initial 2 drills. So here it is after our osteotomes. We've widened our osteotomy. We still have maintained 1.5 millimeters of buccal plate. And the implant goes in with a slot, which indicates the hex for the restorative components on the direct buccal. And just confirming that we're not fenestrated or stripped out the buccal as well. So here's a better shot all the way down the buccal plate. We can see no implant threads, no show through of the implant. This implant is placed fairly deep. You can notice it's probably about 1.5 millimeters below the plate, where the bone does get a little bit thicker, which was the plan. And you can even appreciate here, it would have been very difficult to place an implant in the number 10 site and be maintaining those ideal dimensions for implant to implant spacing. So I wasn't very happy with how thin that buccal plate was, so we decided to add a little bit of xenograft. This is about 1/4 cc of Mineros X, which is their porcine xenograft, very small particle size. And I've got a suture in there that is pre-sutured into the periosteum deep to the flap just so that I can easily get a sling suture. There's what you can't see in this picture is there's a pericardium membrane between the flap and the bone graft because it's just a little bit too bloody and buried up there. Healing abutment placed after bone profiling to make sure that healing abutment fully seats. And then you can see here a horizontal mattress suture on the buccal and a couple of interrupteds to tap that down. And a final PA. And there you can also appreciate the fracture, the previous traumatic fracture on number 9, that's asymptomatic. So just confirming the healing abutment is fully seated. We're nowhere near the other roots. And we have a little bit of bone graft there as well. So pre-op and post-op CT. The pre-op plan, you can see we knew it was very, very thin. If we had gone to final drill, we would have probably been able to see the implant. But since we stopped after our 2.0 and our 2.5 and did osteotomes, we were able to maintain most of that buccal plate width. And so in our post-op, you can see the bone graft there because it's a little bit radio dense thanks to being xenograft. So you can see the additional bone graft just to help maintain a little bit more of that buccal plate. So I always, one thing you see when you look at post-op CTs of implants is, boy, oh boy, that looks like it's not in the bone. And one thing we have to be really concerned with is something called beam hardening. And beam hardening is, and I'll read this for you, is the phenomenon that occurs when an X-ray beam comprised of polychromatic energies pass through an object, resulting in selective attenuation of lower energy photons. I have no idea what that means. I almost failed physics in high school. So it's fancy words for saying, hey, it looks like there's no bone around that implant you just placed. And that's another reason I love to have photos, because boy, oh boy, if someone sees this CT outside of my office because I'm out of town or they move and they think, man, that guy was a total hack. It looks like he placed half this implant out of the bone. I can confirm that is not the case. We have a nice 1.5 millimeter thick buccal plate here, but due to beam hardening from CTs, it sure does look like there's not a lick of bone on the top third of that implant. So here's our pre and post-op pano curves. So everything went to plan, and the top surgery was 20 minutes start to finish. The bottom surgery, maybe for another webinar, was a little bit different. But here's our final CT rendering. And that's it. 56 minutes on the nose. It looks like we have a couple of questions, Adam. So let me pull up the Q&A. Okay, so we got a couple of questions here. So Kleeman, yeah. So Mike Kleeman was asking if the number 11 implant sleeve is hitting the mesial of 12. And yet when you're planning it, you do have to be very mindful of that. So when you're in the CT software and you're looking, and we'll go back to it here and I might have planned this a little bit faster. When I am designing this for a, when I'm designing the real one, I would be very mindful of this. And Mike is spot on. This is impinging on number 12. So we'd have to make sure that this implant is moved maybe to about here. And we can see in the slides of the actual surgery that it was not impinging. And the BioHorizons sleeves do have, and we'll go back to show you, there is a flat edge. You can see, and I actually don't even have it turned in the right direction, but if that flat edge, I would position that intentionally towards where there's more likely to be impingement. Alternatively, you could take a high-speed carbide burr and cut the portion of the guide sleeve that is impinging on number 12. But yeah, it's very, very, very close, but I made sure when I was in the software that it wasn't. I think when I was doing the demo, it looks like I got a little bit close. So yeah, that would have been impinging. It's something you would have had to know going into surgery, certainly. So, and then Alfonso asked a similar question. What if your guide sleeve impinges? Now, what do you do if you can't help it? Let's say number 5 was actually such a small space that it didn't matter where we put this since impinging. What would you do? Well, you would switch to a pilot guide. You would use a 2.0 sleeve that is simply for the pilot, which since I only use the 2.0 drill in this case, I certainly could have done that. I wasn't sure if I was going to place the implant through the guide at the end, so I was considering doing a 2.0 drill, the osteotomes, and then I might do the implant through the guide. And so I wanted the fully guided sleeve available. But if that's not an option, yes, you could do a 2.0 or a pilot guide only. That would have a much, much smaller sleeve. Yeah, good questions. What else do we got here? Do you insert the drill sleeve before or after curing the surgical guide? I do it before. I found that if you wait till it's been cured, it's a lot harder. And you then have to ream out the inside of the guide sleeve portion. So I'll do it right after it's been washed. So after it's come out the isopropyl washing wash system. I'll go ahead and put that in. It goes in pretty easy. Looks like that was a couple of questions there. How do you put the implant timing in the guide? That's a great question. A couple ways you could do it. There are some sleeves that will actually appear. Let me go back to. So these little notches, you could certainly, the straight edge or these little notches, you could intentionally line that up in your guide knowing, hey, this is where I want the timing to be. And that way, when you do, if you did it fully guided and we were placing it fully guided, I know I have an example of it here, you'd be able to see where that slot is, right? Alternatively, you can always place the implant through the guide and then take the guide off and visualize and confirm exactly where that timing is. One other option in the software is you could use that smooth or remove tool and make a little notch in the guide itself. And so you would have it on the physical guide, right? How do you know if you've placed your implant deep enough? Good question. If you're doing the fully guided, I could have placed the implant through the guide using that stop position. I knew it was stop position 3, and then I would know that it was planned to the depth that I had it planned. As far as implants in general, you want them to be roughly 3 to 4 millimeters from the future free gingival margin. So you have enough running room for it to emerge from the implant and have a kind of a natural emergence profile. We don't want to have anything too shallow where it needs to come out and immediately jut out and have what looks like a tomato on a stick, right? So we want to have it deep enough that we have a natural emergence, but it can't be so deep that you're starting to damage the bone and periosteum on the adjacent natural tooth. So if we're too deep, we're going to get a kind of a natural vertical defect there between the two teeth. So there's a fine balance there, and 3 to 4 millimeters from the free gingival margin is typically what we're looking for. Kieran has a good question. How do you plan to place implants in guided surgery if you have to do a direct sinus lift? I've done it several ways. I've actually done 2 guides before. So let's say, for instance, that we're going to take this implant, we're going to put it in the molar. And let's pretend like the molar is not here, okay? I would take this implant, I would make one guide right here. I would make one guide, this would be my drill guide, and I would make it 1 millimeter short. And I would write on the guide in the software, because you can add words, I would say drill guide. And then I would have a placement guide that would be like this. And so with the first guide, the sleeve is down here. The guide says I'm doing my drilling, and I'm only drill probably the 2.25, switch to osteotomes or whatever Versa, whatever your direct technique is. And then once that's all done, I have my bone graft, it looks beautiful. I'll slap on my placement guide and place my implant through the placement guide. Alternatively, you could just not have a placement guide and place it freehand. There's any sort of combination of those too. Okay, yeah, I think that's about it. So thanks, everybody. I got it just in over an hour. So thanks for staying up late if you're on the East Coast. Here in Arizona, it's only 6 o'clock. So I got the whole evening to look forward to. But I appreciate you guys coming out. Looks like we had quite a few of you hang around. So I appreciate that. And there's my contact information. Like I said, follow me on Instagram if you want to see a little bit more of my day-to-day. I like to post at least a couple times a week. And then my email if you have any questions about our programs here at Implant Pathway or any questions about Acteon or SprintRay. All right. So thanks, everyone, for coming out.
Awesome. Good stuff. Thank you, Dr. Vorholt, for the amazing presentation. You were not lying. Lots of content.
We got through it all.
You certainly did. Like you said, anyone has questions, feel free to reach out to Dr. Vorholt directly, or if you're interested in adding 3D printing to your practice or have any additional questions, please feel free to email us at webinars@henryschein.com. Tonight's webinar was recorded, so we'll shoot that over to you in the next week. And that's all I got. So thanks for attending. Have a great night.